Welcome to the EAU podcasts. In this episode, UROONCO Bladder Cancer Chief Editor Dr. Pradere talks to Dr. Guerrero-Ramos on the first result from cohort 4 of SunRISe-1 trial.
Dear friends, dear colleagues, it's a pleasure for me to be with Dr. Félix Guerrero-Ramos from Spain, Madrid, today in Las Vegas 2025. Félix, thank you for being with us today.
Thank you so much, Benjamin.
We had the chance to see you presenting new data released from SunRISe-1. SunRISe-1 is one of the awaited trial regarding BCG unresponsive patient in this field that is moving so much recently. You have already presented some early data regarding SunRISe-1. There are several cohorts. Can you just remind us how SunRISe-1 has been designed and what was the first design of the cohort you were presenting today?
Well, SunRISe-1 is a trial for those BCG unresponsive, non-muscle-invasive bladder cancer patients. It's a phase 2B trial. The main cohorts are cohort 2 and cohort 4. Cohort 2 is for those CIS with or without papillary disease patients. And cohort 4 is designed for papillary-only disease patients who are BCG unresponsive, of course. Here at AUA, it was presented an update on cohort 2 and the first results of cohort 4.
Thank you. So the cohort that you have presented, can you explain to us what were the results?
We presented the first results of those patients with papillary-only disease who are BCG unresponsive. There were 52 patients treated with TAR-200 every 3 weeks for the first 6 months and then every 3 months up to 2 years. The primary endpoint was disease-free survival and secondary endpoints included safety and tolerability. What we found was that regarding disease-free survival, at 6 months, 83.5% of the patients remained disease-free, and at 9 months, significant 81.1% of the patients remained disease-free. These are very promising data, and soon we will be able to report the 12-month recurrence-free survival. If we split the patients in those high-grade TA and those T1 patients, we see that TAR-200 is highly effective in both groups. So its efficacy remains high irrespective of the T stage. And overall survival and progression-free survival were excellent, 98 and 95.6% respectively at 9 months. And regarding tolerability, no new signals were detected. We know that TAR-200 is very well tolerated. There are no safety issues. And 99.5% of the insertion procedures were successful. So this is an easy to administer therapy.
I think it's also important to remind that in that cohort, there were no sertralimab given to the patient. So it was just to assess the efficacy of the intravesical device who is delivering the gemcitabine. I think this data, although the number of patients remains still low, the RFS is really promising so far. We also had the presentation of the other cohort with only CIS, which is the first cohort that we were aware in terms of results. Can you tell us what was interesting? And we were awaiting for the duration of response in this specific field of CIS unresponsive patients.
We already knew data from the cohort 2, which is for CIS with or without papillary tumors. Let's remind the audience that among all BCG unresponsive tumors, only 10% of the patients will harbor CIS with or without papillary. So the biggest population is papillary only. In this cohort, where the complete response rate remains as in previous reports, around 82%, which is the highest so far. The duration of the response is approximately 50% at 1 year. So in comparison, we should not do comparisons across trials, but we usually do in comparison with other drugs. These are the best results reported to date.
Yeah, indeed. We have a lot of new drugs that were starting to look at this BCG unresponsive patient, especially in the setting of CIS, because of FDA requirements. We choose firstly the CIS. It's also important to understand why we move from CIS to then papillary-only BCG unresponsive tumors. Maybe you can tell us, now we see that there are many drugs that are coming on the market. There were also other presentations like the Bond 003 trial with one cohort presented today. What do you think and how should we, as a physician, look at this data and look at this study to decide how we're going to make the decision to treat the patient in another way than radical cystectomy?
Well, this is a very crowded scenario right now. Many drugs, many new mechanisms of action, genetic drugs, gene therapies, TAR-200. The data presented from CG0070 from the BOND-3 trial revealed that their complete response rate maintains, according to previous reports, around 70-something%, 3 months. So it's a very nice complete response rate. We know that in Europe, we do not have any approved agents. There are 3 approved agents in the US for CIS, BCG unresponsive, not in Europe. I hope these new numbers and all these trials translate into some approvals by the European Medicines Agency. And in the future, we'll have for sure to individualize the patients. I am sure we will be performing much less radical cystectomies, but still there is a profile of patients that might need an upfront radical cystectomy when the BCG unresponsiveness is detected. It's not the same a patient with some CIS that patients with 3 big T1 tumors with lymphovascular invasion, with CIS and all that. So we will have to work a lot on medical education to select profiles of patients who are candidates for each of the therapies.
Yes, thank you very much, Felix. I think you raised 2 really, really important points for us to understand the future of this. First of all, we are going to see what the authorities will accept and the reimbursement, because it's good to see that we have new drugs, but we hope that Europe will be able to use them. And that's so far a real issue to get the new drugs on the market in Europe. And the second point, as you said, all these drugs won't be for every patient. And I think it's a really, really important take-home messages anyway, that we still have to personalize the treatments and to select the patient that will be able to receive this kind of treatment without having a radical cystectomy. Because, for example, we know that we have the gemdose that is, of course, off-label in Europe, already really used in US, but still we see some progression, and usually the progression are more metastatic. So if we miss the window of opportunity to do the radical cystectomy, we will have some dramatic outcomes. So, as you said, it's very important to look at this data properly, to wait a bit for more follow-up in some of them, and then maybe decide which patients are the best for these drugs. Thank you very much, Felix, for your time. Congratulations for this presentation, and I hope to see you soon.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.